Welcome to all present. This is Dr. Senthil Kumar, and I'm here to discuss about the latest update on hypertension. And according to WHO criteria, almost 27% of deaths are accredited to cardiovascular disease. And one of the main risk factors which are associated with cardiovascular death seems to be hypertension. Just imagine 27% of cardiovascular deaths, of which hypertension is one of the heavy risk factors. And one more important data which I want to mention here is almost 50% of men and 40% of women. In fact, 50% are unaware that they are having hypertension. That is, they don't know that they even have increased blood pressure. 50% of men, just imagine, 1 in 2 do not know that they have increased blood pressure. And another important data, all these are given by World Health Organization. So 62% of men and 53% of women, all what I'm telling is Indian criteria, Indian. So Indian data given by WHO, 62% of men and 53% of women don't get treatment even if they know that they have BP. So one is 50% of men don't know that they have BP. So they have not been diagnosed. They don't know even though they have BP. Another criteria is 62% of men know that they are having increased BP but they don't take treatment. So such is the burden of hypertension in our Indian scenario as per WHO, and it's in fact a very heavy burden. So to make it very simple, almost 1 in 5 male is only getting treatment for hypertension and 1 in 4 female is being treated for hypertension. And all these are latest 2021 guidelines given by WHO. And again, I will want to go to the guidelines of AHA, American Heart Association 2021. What it tells the new guidelines is that when your systolic BP is less than 140, and diastolic BP is less than 90 millimeter mercury, and our ASCVD, that is atherosclerotic cardiovascular risk factor, it is a calculator which you use to calculate the risk. ASCVD risk factor is less than 10%. That is, systole is less than 140, diastole is less than 90, and ASCVD risk factor is less than 10% or zero risk factor means no need to start antihypertensive therapy. Or this is like stage 1 hypertension with zero risk factor for cardiovascular disease. We need to just observe and follow the lifestyle modifications and no need for any antihypertensive drugs. So lifestyle modification like DASH diet, that is dietary approach to stop hypertension, where we will be advising the patients to have salt restricted diet, no oil rich foods, regular walking, at least 150 minutes per week of exercise. So, and inspect after following these lifestyle modifications, or if they're not going to follow, when they come back for 3 months, if they're going to have almost same BP, like 140/90, then we may go for antihypertensive drug therapy. This is stage 1. Another criteria, AHA 2021 says that if your systole is 150 and diastole is 100, then definitely you have to go for antihypertensive therapy. The catch in it is the latest guideline says that instead of going for monotherapy, when the diastole is more than 100, it is better to start with fixed dose combination of 2 drugs. That is, instead of a monotherapy, single drug, we can straight away start with 2 drugs when your diastolic BP is greater than 100. That is also important criteria. So among the 2 drugs which you can choose, it depends upon the ASCVD risk factor also. So in general, we start with RAS, that is either AC inhibitors or ARBs, and the second drug can be either calcium channel blocker or diuretic. So RAS includes AC inhibitor or ARB, and we have to remember that always never combine AC inhibitors and ARBs because they are both going to act with the same mechanism. That is very important. Another point which I want to mention is very, very important, nighttime BP. So yeah, this is a common question even doctors ask, when should the antihypertensive drug be started, whether in the morning or because some doctors start the antihypertensive drug in the morning, some doctors prescribe it in night. So for that, I would like to mention a trial here, HYGIA chronotherapy. That was also in the year 2021. It is a very large trial, HYGIA, HYGIA chronotherapy. And in the trial, what they found out was the cardiovascular events was very much improved. The cardiovascular events was very much improved with the nighttime treatment rather than day treatment. Otherwise, the relative risk reduction was found to be better with the night treatment. So it doesn't mean that antihypertensive have to be started only in night, but the study, the HYGIA chronotherapy study showed that nighttime BP treatment, especially when you are starting calcium channel blockers with AC or ARB, it is better preferred that it can be given at nighttime. Because another data I want to tell here is whenever your nighttime BP or midnight BP, systolic is greater than 20 and diastolic is greater than 10 mmHg in the night time, then the mortality is increased by 23%. And the risk of cardiovascular event is also 36% increased. This is just based on the nighttime BP recording. I again repeat, when your nighttime systolic BP is more than 20 and nighttime diastolic BP is more than 10 mmHg than the standard BP, the mortality rate is increased to 23%. So this is also an important data which shows that nighttime BP dosing may be better compared to morning, but again, it has to be individualistic depending upon the status of the patient. And another interesting thing in ACC, American College of Cardiology, and also in the journal, which was published again in the year September 2021, it showed a beta blocker, that is metoprolol, reduces the lung inflammation, especially during this COVID, especially in the second wave of COVID, we saw many lung inflammation and they were suffering, in fact, with ARDS also, that is adult respiratory distress syndrome. So apart from the beta blocker effect of metoprolol, metoprolol also showed to be very, very effective in reducing inflammation in lung. So in ARDS patients with hypertension, so this metoprolol drug also could be chosen. That is was also found out in the journal published by Cardiology in 2021. And again, step trial, sprint trial, two are that is sprint trial. What they showed that how much your BP has to be controlled. I told that when our BP is less than 140/90, go for lifestyle modification, no need to start drug. But even after 3 months, if it is not controlled, then we have to think of starting a drug. And in this sprint trial, what it showed was how much your BP has to be decreased is up to 110. So from 130 to, or you have to maintain the BP from 110 to 130 to prevent cardiovascular events or to decrease the cardiovascular events. That is also very important. So to summarize, our Indian scenario, almost 1 in 2 is not knowing that he is having hypertension. That is 50% of men and 43% of women. And among that, 53% of men who knows that they are having BP, they are not taking BP medication. So to summarize overall, 1 in 5 men and 1 in 4 women are not taking BP medication, which is really a drastic scenario because hypertension is a very important risk factor for cardiovascular event. And the cardiovascular events itself is around 23% of mortal rate, especially in Indian settings. So we have to see that we follow the proper lifestyle modification like DASH diet, dietary approach to stop hypertension, salt restricted diet, and see that we take our medications regularly, especially when our diastolic BP is greater than 100. And very, very important is nighttime BP monitoring. So here also we have a AMBG, that is ambulatory blood pressure monitoring, AMPM. So ambulatory blood pressure monitoring is 24 hours BP recording, where we can find our nighttime BP recording, whether it is high or less. As I was telling about the data, when our nighttime systolic is greater than 20 and nighttime diastolic is greater than 10, there is a probability of 23% increase in mortality and 36% increase in cardiovascular events. So all these can be avoided by doing ambulatory blood pressure monitoring. And regarding the drug dosage also I mentioned, you can go with the fixed dose combination if your diastolic is greater than 100, and that depends upon the standardized individualized patient whether it has to be given in morning or night. Preferably if you are going with angiotensin receptor blocker and calcium channel blocker, the combination is better to be given in the night time. As I told one study also, IGIA study, which clearly mentioned that the nighttime elevated BP is directly related to increased cardiovascular events. That is, relative risk factor was comparatively less when the BP medication was given in the night time rather than in the early morning. So with this, I will conclude my talk on the latest guidelines on hypertension. Thank you.